Good afternoon, everyone, and welcome to our latest ARC Talks webinar. I'm really delighted to have Dr. Mazen Hanna here today, who will be talking about cardiac devices in amyloidosis and the role that they play. He is a physician known to many of us and has been really instrumental in establishing a phenomenal amyloidosis program at Cleveland Clinic. He's also done remarkable work in identifying bilateral carpal tunnel and earlier identification of patients with amyloidosis. So his research has really contributed to the knowledge and understanding of amyloidosis. Just by way of background, ARC Talks is brought to you by the Amyloidosis Research Consortium. I'm Isabel Lisada, the CEO and founder. We really are focused as an organization on making a significant difference to the curability of amyloidosis and accelerating research. We have 4 areas of focus: improving the speed and accuracy of diagnosis, increasing the understanding of the biology and natural history of amyloidosis, accelerating regulatory approval for faster treatments to get developed and treatments that matter to patients, and enhancing the care and quality of life for patients with a number of programs. And ARC Talks is one that falls within this. Educated patients do better, they get better care, they can advocate better. So learning about the disease that you have is really critically important. So in today's webinar, we'll start with Dr. Hanna giving us an overview, and then we'll have time for question and answers. There is a question and answer box, a question box. And so throughout the talk, feel free to write your questions in, and then we'll come back after he finishes and go through the questions. Thank you. And without that, I will now hand over to Dr. Mazen. Dr. Hanna, thank you.
Thank you very much. I just need to share my talk here. I really appreciate, Isabel, all that tireless work that you and your team is doing at the Amyloid Research Consortium to help our patients. And as Isabel stated, the title of this talk is Devices, basically cardiac devices for heart improvement in cardiac amyloidosis. These are my disclosures. Another disclosure that's important is I don't put in devices. I'm not partial to any of these devices. I have no relationships to disclose. Some of the name brands of these devices you'll see are just because that's what I had on my desk to take a picture of. This is really just to make you aware of some of the devices out there and the issues that come up with cardiac amyloidosis that may make them relevant. Just by way of background, I always start with this slide. There's 2 main types.
We can't currently see your slides.
You cannot currently see my slides. Okay. I thought I did share my screen, but let's try again.
Yeah, there you go.
Oh, okay. I'm very sorry. So maybe I'll just go to this slide again. These are my disclosures. So I will start by way of background to delineate the 2 main types of amyloidosis that affect the heart. The first one on the left is AL, or light chain amyloidosis. In this case, the protein forming the amyloid fibrils comes from a clone of plasma cells from the bone marrow. And the light chains, which are fragments of antibodies, are what form the amyloid fibrils that deposit in the heart. That is more rare than the more common type, which is called ATTR, or transthyretin amyloidosis. In this case, the protein that's forming the amyloid fibrils comes from the liver, and it misfolds and aggregates. And in both cases, the amyloid fibrils deposit in between the muscle cells, thickening and stiffening the heart. And when you look under an electron microscope, you see these rigid non-branching amyloid fibrils that are causing the issues in cardiac amyloidosis. So this is a cartoon of the 4 chambers of the heart and the aorta. So let me take you through this. Obviously, this is from the patient's perspective facing us. This here on the bottom is the left ventricle, and the other chamber on the bottom is called the right ventricle. And these are the chambers that are filled with blood and pump blood out to our body. The left ventricle pumps out the aortic valve to the aorta. The right ventricle pumps blood to the lungs. Now, when the blood comes back from the lungs full of oxygen, it comes into something called the left atrium. And the left atrium then the mitral valve opens, the blood comes into the left ventricle, squeezes out the aorta. And there is something called a left atrial appendage. There's a little outpouching in the left atrium that can sometimes be a nidus for a clot to form in patients who go in atrial fibrillation. This here, the right atrium, is where the electric pacemakers of the heart, called the sinus node, are. And these typically beat between 60 and 100 beats per minute, and the electrical activity goes through the atrium to what's called the AV node, and then down what we call the septum of the heart, which is the shared wall between the right and left ventricle, and then is supposed to quickly electrically deliver the signal for the heart to contract simultaneously. So the issues in cardiac amyloidosis that can occur is atrial fibrillation, where the heart goes out of rhythm and you can form blood clots in the left atrial appendage. The stiffening and thickening of the left ventricle and the right ventricle can cause symptoms of shortness of breath and swelling. We call that heart failure. You can get conduction problems of the electrical activity, slowing the heart to the point where you may need a pacemaker. And sometimes you can get ventricular arrhythmias. We call that ventricular tachycardia, that may cause people to pass out. So when it comes to devices, it's really in the context of 4 issues that occur in cardiac amyloidosis: atrial fibrillation, heart block, ventricular tachycardia, and congestive heart failure. And so to start with atrial fibrillation, there are a couple devices that you should be aware of. Now, atrial fibrillation in cardiac amyloidosis is not uncommon. In fact, patients with wild-type ATTR, up to 70% at some point during their condition may develop atrial fibrillation. It's not as common in AL amyloidosis or the hereditary forms. And it really occurs because the amyloid is directly infiltrating the atria, leading to that susceptibility. So to understand atrial fibrillation, let's first understand what a normal electrocardiogram is, or the other names you may hear for it is ECG or EKG. And basically, what you're doing is putting electrodes on the chest, and then you're running it through a machine to see the electrical activation of the heart. And so what you see are basically 12 leads. Each lead is looking at the heart from a different vantage point. But the first blip you see here is when the atrium contracts. Then there is a period of time when it's conducting down to the ventricles, usually no more than 0.2 of a second. And then the sharper deflection is when the ventricles are squeezing and are activated. So when the sinus node fires, you get this atrial impulse. Then there's no more than 0.2 of a second by the time it reaches what we call the AV node, then travels down the septum, and is supposed to travel rapidly to form a very narrow, sharp deflection of electrical activation of the ventricles, which leads for them to squeeze shortly after the atria squeeze. So that's called normal sinus rhythm. So when you have infiltration of amyloid by the atria, instead of the electrical activity being coordinated and organized with the atria beating just before the ventricles, the atria can start to fibrillate or quiver. And what you see here is you still see the ventricular sharp spikes, but instead of seeing those very clear P waves, you see this almost fibrillatory waves. That means the atrium, instead of contracting in an organized fashion, is kind of quivering or fibrillating. And not only do you see that, but the heart now is irregular. Instead of beating in a regular rhythm, in a regular cadence, it'll be irregular. And some patients will feel palpitations because of the irregularity or because the atrial fibrillation leads to a fast heart rate. When the atria are no longer contracting and pushing the blood through in an organized fashion, that area that I showed you, the left atrial appendage, because there's stasis and poor flow, it can sometimes lead to a formation of a blood clot right in this area. And that is concerning because if there is a clot in the left atrium, some of that clot breaks off, it can go into the left ventricle, ultimately be pumped out the aorta and potentially cause a stroke. So that's one of the main concerns when somebody goes into atrial fibrillation, above and beyond just causing palpitations. So Anticoagulation basically means being on a blood thinner. So when patients go into atrial fibrillation and they have cardiac amyloidosis, they're at particularly higher risk of forming a clot in the left atrial appendage than perhaps other causes of heart problems. And the blood thinner thus is recommended. So any patient who has cardiac amyloid and they have AFib, we by default recommend a blood thinner in those patients. Now, the traditional blood thinner historically was Coumadin or warfarin. There are now several other blood thinners that are much easier to manage. Some of you are on these medications such as apixaban, otherwise called Eliquis, or Xarelto, otherwise rivaroxaban, Pradaxa, which is dabigatran. Nonetheless, regardless of the blood thinner that's chosen, the purpose of the blood thinner is to decreases the chances of forming a clot in the left atrium and decrease the chance of having a stroke. So this is an echocardiogram. This is called a transthoracic echocardiogram. The probe, the ultrasound probe, is on the chest of the patient. And it goes through the skin, through the lungs, through the muscles, and reflects back an image of the beating heart. So this right here is the left ventricle. This is the blood. That's the mitral valve opening. And the blood is coming back from the lungs into the left atrium, into the left ventricle, squeezing out the aortic valve to the aorta. And this over here is the right ventricle. Here you can see that the ventricle is thickened, more thicker than usual because there's cardiac amyloidosis. But what you can't see here is the left atrial appendage. That outpouching is very hard to see when you're doing a transthoracic echo. That's the echocardiogram where they put the probe on your chest with that jelly and they make pictures. So if you're trying to rule out if there's a clot in the left atrial appendage, a transthoracic echo is not sufficient. And there's something called a transesophageal echocardiogram you should be aware of, otherwise called TEE. And this is a probe that, just like if you're getting scoped for an ulcer, same kind of thing. This probe has an ultrasound on the end. And when you go down the esophagus runs right behind the left atrium. And you have a very clear window into that left atrial appendage to see if you can rule out or rule in if there's a clot there. So this is what it looks like when you do a TEE. This is a view where here you can very clearly see the left atrial appendage, and you're looking to see if there's a clot in there. And here you can actually see that this is supposed to go all the way down here. There is a clot in this left atrial appendage. And so this is something we do if we want to get somebody out of atrial fibrillation with a cardioversion, which means electrically stopping the heart with defibrillator pads under controlled anesthesia to bring back the normal rhythm. We often will want to make sure there's no clot in the left atrial appendage with a TEE, because if there is a clot, we don't want to shock the heart back into rhythm, because that can lead to a possible dislodging of that clot and causing a stroke. So if your doctor says, I need, before I do a cardioversion for your AFib, a TEE, this is what they're referring to. The risk of a TEE is quite low when done in experienced hands. They do numb up your throat. They do give you some relaxing medicines. And it's relatively quick procedure just to go in and rule out the clot in the left atrial appendage. So intracardiac thrombosis, or clots in cardiac amyloidosis, are not uncommon. In one Mayo Clinic series of 156 patients who had a TEE, 27% of them had clots in the heart, most of them in the left atrial appendage. And the highest risk for forming a clot in the heart in cardiac amyloidosis is if you have atrial fibrillation. There's another study specifically in ATTR cardiac amyloidosis in patients who had atrial fibrillation. 100 of them had a TEE at the Cleveland Clinic. The majority of these patients were already on a blood thinner, and yet 30% of them had a thrombus or a clot in the left atrial appendage. And now traditionally, when a patient has atrial fibrillation, to make a decision whether or not they need a blood thinner, there's something called a CHA2DS2-VASc risk score. And you add up all these different things, such as, has the patient had congestive heart failure? Do they have hypertension? Are they over age 75? Do they have diabetes, etc.? And typically, if your score is over 1 or 2, that patient should be on a blood thinner. But an amyloidosis, as you can see, is not delineated in this risk factor score. So it doesn't take into account the high risk of clots in the left atrial appendage in people with amyloid. So we will tell patients, regardless of the CHA2DS2-VASc score, if you have cardiac amyloid, you should be on a blood thinner to reduce the risk of stroke. So one of the issues is patients who actually get put on a blood thinner, some of them can have bleeding issues. Some of them can have blood in their stool. They can become anemic. And we run into this problem where we have to stop the blood thinner, yet we're no longer as protected against stroke. So one of the potential devices you'll hear about, they're called left atrial appendage occlusion devices. In this particular case, and again, I'm not partial to them, these are watchman devices. And the concept here is that these devices can be placed to exclude blood flow into this area of stasis, which is the left atrial appendage. And by putting this here, the body's own tissue will grow over it. And now when someone is in AFib, the blood cannot go down into the left atrial appendage and cause a clot. Traditionally, these are put in patients who have problems with bleeding and need to be off a blood thinner. Usually you need to be on a blood thinner for at least 6 weeks while this heals, but ultimately, if the watchman or the left atrial occlusion device is placed appropriately with no leak, the patient actually can then subsequently at some point come off a blood thinner such that they're now protected against stroke, yet they don't have to deal with the potential bleeding issues of the blood thinner. There's no good data in doing this in patients with cardiac amyloidosis. Your doctor may or may not recommend this. We've done about 10 to 15 now in the Cleveland Clinic. For the most part, it's gone well, but I would be lying to tell you if I had enough data to support this practice. Sometimes when push comes to shove and we're having recurrent bleeding issues, we have bitten the bullet and put this device in, and we're hopeful that this device will prove at some point to be safe in patients with cardiac amyloidosis. So this is a 69-year-old patient with ATTR wild type and AFib that's called paroxysmal. It comes and goes. And the patient feels better when they're in normal rhythm. Doesn't feel awful when he's in atrial fibrillation, but feels better when he's in normal rhythm. Can exercise longer. And here you can see the left atrium is not particularly enlarged. And so one of the questions comes is, what about an ablation for atrial fibrillation? What is an ablation? Well, we know in the left atrium, the triggers for the atrial fibrillation typically come in tissue right around these 4 pulmonary veins. So remember, the pulmonary veins drain the lung, the oxygenated blood from the lung into the left atrium. And in the left atrium, there are electrical areas that can precipitate atrial fibrillation that with an ablation catheter, you can cross through the inner atrial septum from the right atrium to the left atrium and basically try to ablate or burn the circuits that are coming or emanating from these pulmonary veins and try to make sure that atrial fibrillation no longer comes back, or if it does come back, much less so. So that's called an atrial fibrillation ablation. These are done by cardiologists called electrophysiologists. This is a several-hour procedure. And the question that has always been raised is, can this be effective in cardiac amyloidosis? If you have amyloidosis in the atrium, is that just not going to work, or can it be effective in selected patients? So one study of 72 patients with ATTR and AFib at the Cleveland Clinic looked at 24 patients who went on to get AFib ablation and compared them with 48 patients who had AFib who were just treated with medications and were not treated with AFib ablation. And they tried to match these patients based on age and stage of ATTR, et cetera. And basically what they're looking to see is how effective is AFib ablation in these patients. And what they found is they did it in 14 patients who were in the earlier stage of ATTR cardiac amyloidosis. 9 out of the 14 actually, out to 3.5 years, were still in normal rhythm. Yet the patients who are in the more advanced stages of the disease, 9 out of 10 were all came back, the AFib came back by 3.5 years, suggesting that in earlier disease and patients who are not in very long-standing AFib, meaning they're just starting to have AFib, a strategy of ablation may actually potentially be successful at maintaining normal rhythm and preventing or at least lessening the degree of recurrence of atrial fibrillation, and that's good for some patients. Some patients feel better in normal rhythm. Now, one thing it's important to note that even though you go back in normal rhythm, that does not mean you can come off a blood thinner, because patients may go in and out of AFib for periods of time without knowing. So if you think you're in the clear and you stop the blood thinner, you're still potentially putting yourself at risk of stroke, because you can have periods of AFib that are not detected by your symptoms. One of the things that happens with atrial fibrillation is sometimes you go into AFib and the heart rate goes 120, 130, 140. Very uncomfortable. You get palpitations, and actually it doesn't allow the heart to fill appropriately. And patients can get short of breath and have heart failure. Sometimes you'll be on what we call beta blockers, such as metoprolol, to slow down the heart rate. Sometimes that's limited by the fact that these drugs can lower your blood pressure. We avoid certain drugs called calcium channel blockers. I've listed 2 of them here because they're not typically well tolerated in amyloid. Digoxin's a very controversial medication to use to slow the heart rate. Traditionally, we've said absolutely don't use that in patients with cardiac amyloid. I think it can be used with caution in appropriate circumstances if your physician's aware of some data and there's no other choices to slow the heart rate down until you can get somebody in rhythm. But you have to be very careful with this medicine, check levels, and I don't recommend routine use of this medicine. Now, trying to get people back in rhythm, some patients honestly feel no different in AFib versus normal rhythm. As long as their heart rate's controlled, they tell you, "Doc, I don't feel any different. I can walk the same distance." And instead of banging our head, cardioverting them over and over and trying to be aggressive, we'll sometimes just leave somebody in atrial fibrillation and just make sure they're on a blood thinner and their heart rate's controlled. Cardioversion, again, is the process of bringing somebody in, putting them under for about 20 seconds, putting 2 pads on the heart, delivering an electric shock, and trying to get them back in rhythm. Sometimes that works and stays for a year. Other times you get somebody back in rhythm, a week later, they're back in atrial fibrillation. There are certain medicines that we can sometimes use to maximize the chance that you'll stay in rhythm. And again, we talked about AFib ablation procedure being safe and feasible in selected patients, not all patients. In selected patients, you can potentially consider an AFib ablation. So let's shift gears from atrial fibrillation to heart block or conduction abnormalities. There's really 2 kinds of conduction abnormalities. One is dysfunction of the sinus node, which is those electrical pacemaker cells that determine our heart rate. And the other is the block between the upper electrical activation down to the atria, down to the ventricles, I'm sorry. So you can have first-degree block or complete heart block, which is more common in ATTR amyloidosis than AL amyloidosis. So this is a 74-year-old male with wild-type ATTR. And this electrocardiogram looks different than the normal electrocardiogram that I showed you in the beginning. So here, as you recall, the atria is activated. Here's the electrical activation of the atria. Then there should only be about less than 200 milliseconds, and then you get this sharp deflection, which means the conduction is rapidly going down the septum into both the right ventricle and left ventricle. In this particular case, you see that the electrical activation, there's a longer pause between that and that deflection is no longer sharp, it's widened. So that means you have delay in the electrical activation from the atria to the ventricles, and then within the ventricle, this is called a left bundle branch block, there's a significant slowing in the ability of the electrical signal to get through the ventricles quickly. So this here is called first-degree AV block and a complete left bundle branch block in the ventricle. Now, this particular patient has no symptoms, but the question is, can this progress to higher degrees of block? And will you have a pause in the heart rate to the point where the patient could potentially pass out? And that's where we talk about pacemakers. This is an EKG that's even got a wider deflection And this Irish variant called the ALA60 variant. They tend to have a higher rate of heart block than other hereditary variants. So we sometimes are more proactive with putting pacemakers in patients with this, we call it the ALA60 variant, or now 80 ALA variant. And this variant, this hereditary variant of ATTR cardiac amyloid, comes from an area in northwest Ireland called Donegal, and that patients often can get thickened hearts, heart block, and sometimes neuropathy. So now what a pacemaker is there's a small incision right under your clavicle where you have this pacemaker, and then there's leads that come down into the right ventricle and sometimes into the right atrium. Occasionally there'll be a third lead that goes over to the left ventricle if you need synchronized contraction. But basically what this does is if the heart's going too slow, the pacemaker will detect that and it will fire the electrical signal for the heart and capture the heart muscle to contract. So that's what a pacemaker is. And if you look at a series, again, from the Cleveland Clinic of 370 patients with ATTR cardiac amyloidosis, the prevalence of high degree AV block at baseline is about 8 to 10%, depending if the patient's wild type or hereditary. And it's most common in this Irish variant, much less common in the African-American variant called V122I. And then if you follow these patients over 2.5 years or so, another 10 to 12% will go on to develop heart block needing a pacemaker. And again, more commonly in the Irish variant. So it is not totally uncommon that a patient with more commonly ATTR cardiac amyloidosis may have to have a pacemaker implanted because of heart block or because the sinus node is firing too quick. So for heart block, these pacemakers now are quite small. They're not high profile. They're inserted under the clavicle. This is a 3-lead device. We call this cardiac resynchronization therapy. We're not going to get into that today, but these pacemakers get smaller and smarter, and you may or may not need one of these implanted for your condition. This is a 78-year-old male who's out of rhythm. It's called atrial flutter, who's got a pacemaker, and it's hard to see this, but there's these little pacemaker spikes. So this patient would not have a ventricular beat if the pacemaker wasn't stepping in and pacing this patient. So this is an example of an EKG where the patient actually is dependent on the pacemaker. So what if you have a pacemaker in for years and you're pacing from the right ventricle? Can that cause a problem? In some patients, that pacemaker can cause dyssynchrony of the left ventricular activation and sometimes lead the ejection fraction to go down. And so there are times where your doctor may say, we have to upgrade this device to put a third lead to resynchronize the heart. That's called a biventricular pacemaker, which has 3 leads coming out of it. So we looked at cardiac resynchronization therapy or biventricular pacing in 30 patients with ATTR cardiac amyloidosis versus 30 who didn't. Again, these are retrospective studies. These are different patients, so you try to match them the best you can. But it suggests that the prognosis is better if you have an issue with dyssynchrony and you put a biventricular pacemaker. It may help. Again, no big studies to guide us. This is a 63-year-old white male who was presenting with passing out spells. And when he came in, you can see his atrial beats were many. This is called atrial flutter, a cousin of atrial fib. And he was in complete heart block to the point where the heart rate was only going about in the 40s. And so this particular patient was put on an intensive care unit on a telemetry for, and this is what heart block looks like. Here, the impulse is getting to the ventricles, and then all of a sudden you have complete heart block, and only the atria is beating. So all this time, the ventricle's not beating, the patient's not getting blood flow to the brain. This is called complete heart block. And for this patient, this is what the echo looked like, was diagnosed with ATTR amyloid with a positive technetium pyrophosphate scan. And here you can see on X-ray that he had a pacemaker implanted. Here's the pacemaker under the left clavicle. Here's the lead in the right atrium. And then here's another lead in the and the right ventricle. This is called a left bundle branch block lead, which I'm not going to go into. But bottom line is this patient, since he's had the pacemaker, has not had any further issues because there's no more heart block because the pacemaker is taking over the activation. So then there's something called VTAC or ventricular arrhythmias. Here, this is not in the atria. This is where the ventricles, instead of being organized, can all of a sudden flutter and cause palpitations. And you've heard of defibrillators that can sometimes be put in to protect against more prolonged ventricular tachycardias that theoretically could be dangerous. And these are, defibrillators are same thing. There's a lead that goes into the heart that monitors the heart rhythm. They tend to be a little bit bigger, but these are also getting smaller. And basically what it does is it's not pacing the heart. It's not doing anything to the heart. All it's doing is monitoring the heart rhythm. And God forbid, if there's a more dangerous rhythm called ventricular tachycardia in the ventricle, and it goes long enough, it will recognize it and shock the heart back to rhythm. So these can be life-saving devices in appropriately selected patients. Now, ventricular arrhythmias and cardiac amyloidosis and putting it in a defibrillator, there's really no good data to guide us. This is a case-by-case basis. There may be individual patients who have VTAC who would require a defibrillator, but routine use in cardiac amyloidosis is not recommended, and we don't have enough data to guide us on that. There's two studies looking at putting defibrillators in prophylactically, meaning to prevent a possible event in patients with ATTR who had lower ejection fractions. Usually in other heart problems, the indication to put in defibrillators if you have an ejection fraction less than 35%. However, in patients with ATTR cardiac amyloidosis who have an ejection fraction of less than 35 or 40%, the data isn't really solid that we're helping people, because most patients with ATTR cardiac amyloid, although they will have short runs of ventricular tachycardia, they don't tend to be sustained or cause major problems. This is a meta-analysis of defibrillators used in cardiac amyloid patients. You can see these case series are anywhere from 19 patients to 45 patients. And when they put in defibrillators, they're used as little as 5% to up to 30%, depending on the cohort. Again, we don't have good evidence to guide us. The Stanford protocol, if a patient has passing out spells and then they put them on a monitor and they find out that they're having VT or non-sustained ventricular tachycardia, particularly if they have AL and they passed out, then those patients will have a defibrillator. Otherwise, they'll continue to monitor the patient if none of those things are met. Some of you will have this patch called a Zio patch or outpatient telemetry, where you put it on for 2 weeks and the doctor will get to see all the different beats. And sometimes you may have, this is what ventricular tachycardia looks. The heart's going along, beating fine, and then all of a sudden you have about a 10-beat run of a fast heart rate coming from the ventricle, and then it goes away. Many patients don't even feel this, or they may feel brief palpitations. And the majority of the time, this does not mean, when they're short-lived like this, necessarily, particularly in ATTR, that you absolutely have to have a defibrillator, but your doctor will individualize that decision depending on the type of amyloid you have, what your ejection fraction is, and how you're behaving. So if you look at the guidelines for defibrillators, it says decisions must be individualized because data remain too limited to make formal recommendations. As published reports on defibrillator effectiveness are small, observational with limited follow-up. And then this ACC 2023 expert consensus on cardiac amyloid, again, they say ventricular arrhythmias are very common in both AL and ATTR. It's not clear if they're predictors of sudden cardiac death, that's cardiac arrest. Although studies have demonstrated appropriate defibrillator therapies in patients, none have convincingly shown improved survival. So again, really, at the end of the day, this is a case-by-case basis that your cardiologist will discuss with you. The last thing I'm going to discuss is fluid retention and heart failure. And so many patients, despite diuretics, struggle with coming in and out of the hospital with fluid retention. And sometimes it's very hard when they go home to judge what amount of diuretic they need. And if they're not following up closely, they may retain fluid in between visits and we're not able to nip it in the bud. There is a device called a CardioMEMS device, which is probably the size of a dime or a nickel, which is a sensor that has two tines that can be put in to the pulmonary artery. So it can measure the pressures in the lungs and the arteries, which is a reflection often of how much fluid you have in your system. And so the sensor is there, and there is a pillow that one can lay down, and it will pick up that sensor and measure the pressure on a day-to-day basis. And basically, you get these, just like a blood pressure. You may get a number of 35/15 with a mean pressure of 20, for example. As the fluid builds up, the pressure goes up. So this is linked with the doctors who can put basically red flag alerts if the pressure goes above a certain level. That will alert them prior to the patient becoming too symptomatic, and can intervene with a change in the medication proactively before the patient gains 10, 12 pounds and ends up in the hospital. This is used in patients who have problems with heart failure hospitalizations and all types of heart failure. And basically, the daily readings by the external device are recorded into a kind of a web system that the doctor can use. In the original heart failure trials, it showed a 50% reduction in patients who had these CardioMEMS to guide doctors on how to use the medications. Again, not advocating to put this in the majority of the patients, but some of you have really difficult to treat heart failure. Your doctor may consider putting this in to help guide them. So in summary, atrial fibrillation is common. Blood thinner is recommended in all patients. Now, in patients who have bleeding issues, the device in the left atrial appendage, which we showed, the left atrial appendage occlusion device, is not well studied, but has been done, may be discussed with you. Atrial fibrillation can be used in selected patients with success, particularly if done earlier on. Heart block, complete heart block, meaning a pacemaker, is most common in ATTR, more than AL, and the Irish variant, called the ALA 80 or ALA 60, has higher instances of this. Long-term pacing of the right ventricle may cause a problem, needing biventricular pacing. Defibrillators are not typically useful in ATTR amyloidosis, and they're controversial in patients with AL, and it's a case-by-case individualized decision depending on the patient. And then that CardioMEMS device implanted in the pulmonary artery, which senses the pressure on a daily basis, could potentially help your heart failure doctors manage your fluid retention and your medications. And I thank you for your attention. I will stop sharing.
Well, that was fantastic. I have so many thoughts and questions, and it was really, really great to hear kind of such a comprehensive overview. And I see a lot of questions coming in, so I will jump to those and hold back on some of mine, but I might slip a few in. So let me just start off, and there was one question which said, can you describe how A-flutter is different than AFib?
Yeah. So both of them are atrial arrhythmias. Both of them can lead to an increased risk of stasis in the atrium and blood clot in the left atrial appendage. The difference is in atrial fibrillation, the impulses are chaotic, and they're coming from around the pulmonary veins in the left atrium. Atrial flutter typically comes from the right atrium in a very organized circuit, and that circuit is regular, as opposed to AFib, which is chaotic and irregular. The atrial flutter rate, which is typically anywhere from 200 to 300 beats per minute in the atrium, of course, only a portion of that gets on the ventricles, is more regular. So atrial flutter ablation is much easier and more successful than atrial fibrillation, although both can be done. So they're cousins in some ways, but they can behave differently with respect to where the circuit is and response ablation. Both of them, though, still can cause the heart rate to go too fast. Both of them can lead to clots in the left atrium.
Interesting. So there are a couple of questions around TEEs? When do you need to get one? And also, how sensitive is it compared to like a cardiac MRI?
Yeah, so the question of doing a T, so if let's just take non-amyloid patients. Let's say you have a patient with hypertensive heart disease who goes into atrial fibrillation and they're not in urgent need of a cardioversion. There's two ways of, because you don't know how long they've been in AFib, you have to make sure there's no clot. So there's two ways of doing it. One is if you want to do the cardioversion right away, you put them on a blood thinner and then you go in with a TE. If you exclude the clot, you go ahead and cardiovert them there. Or alternatively, you could put them on 3 to 4 weeks of blood thinner, let them accrue that time with the blood thinner. By that point, the risk of a clot being there is very low. And without doing a TEE, you could go ahead and just cardiovert them. So you can obviate the need for TEE by giving them several weeks of anticoagulation. Now, in cardiac amyloid, I just told you that even on blood thinners, there's a significant incidence of still having a blood clot. So the practice patterns are very mixed. And when I talk to my colleagues around the country, some of them will say, hey, even if I have somebody on 3-4 weeks of a blood thinner and it's new onset AFib, I'm still going to do the TEE to be absolutely sure there's no clot. Others will say, look, there's no data to guide that. Even if there is a clot, they're well anticoagulated. And some doctors will not look as long as they give them 4 weeks of anticoagulation, they will forego the TEE. I tend to, at least that first time, get a TEE on everybody, just to make sure there's no clot in a left atrium before I do a cardioversion, regardless of the fact that they've been on a blood thinner for a longer period of time. If they have AFib again, and I previously ruled it out, I don't go and put them through another TEE again. Remember, it's safe, but you are going through the esophagus and it's, you have to get sedation and all that stuff.
And as far as, so you do it, you see that there's a clot. Is there anything else, you put a patient on blood thinner, is there anything else a patient should be doing or watching for once they've been told that that's the case?
Well, if there's a clot there and you're on a blood thinner, we continue the blood thinner. We really hope that clot's going to gradually dissolve. Sometimes we change from one blood thinner to the other to try to make it go away. And obviously the things to concern are any signs of a stroke, abrupt arm numbness or speech issues or anything that could signify the potential for a clot. Or sometimes the clot can, go to another area, cause abdominal pain or whatnot. I think the risk is very low of having that happen. Even if you have a clot and you're on a blood thinner, I don't think the incidence of those kind of things are high. I don't have exact data to guide you, but yes, that's what they would look for. And then the problem is, if the clot doesn't go away, then we can't cardiovert them or get them back in rhythm. We have to live in AFib.
Interesting. Can you comment on ablation compared to the implantable device as a strategy for AFib?
Well, there's no implantable device as a strategy for AFib in and of itself. I think I can try to figure out what this question is asking. So atrial fibrillation ablation is meant to restore normal rhythm, or at the very least, if they're going to flip back in AFib, they're more likely to be cardioverted and last longer in normal rhythm. There are no devices in and of themselves, apart from ablation, that treat AFib. There is something, when you have problems with AFib and the heart rate's going too fast and you can't control it, sometimes what you can do is literally burn the connection between the atria and the ventricles. It's called an AV node ablation, and put a permanent pacemaker. Now you can control the heart rate. It won't go, you can go whatever you turn the pacemaker to, whatever rate response you put, you're no longer going to have to deal with the fast rates of AFib. And sometimes we'll resort to that. We'll do an AV node ablation in people who have difficult to treat heart rates, and we'll put in what's called a biventricular pacemaker. But I'm not sure that answered the question.
No, I think that was helpful. Can you discuss the effect of an aortic mechanical valve with amyloidosis?
I don't I mean, we know that patients, particularly with ATTR, there's an incidence of aortic stenosis, particularly in older patients, that coexists. And so there are two ways, if the valve becomes severely narrowed, there's two ways to fix that. One is a surgery, an open heart surgery, where you literally have to go in and put either a pig valve, a tissue valve, or a mechanical valve, but no one's really doing that at that age. Or there's something called TAVR, which is aortic valve replacement. Here, you're typically going through the groin in a procedure that is not open heart. You go retrograde across the valve, and there's a balloon-mounted valve that you blow up, crushes the old valve to the side, and basically restores the opening there, and you go home the next day. So that's called TAVR, and that's pretty much revolutionized our ability to treat severely narrowed valves, particularly in older people who are not surgical candidates, who are worried about risk. So initially the thought was, why would you do a TAVR in an older patient with AS? Their prognosis from the amyloid is going to create a problem before the severely narrow valve. But now that we have treatments for ATTR, we're doing the TAVR and we're treating the ATTR. So we're dealing with both.
So we have a couple of questions about pacemakers, and can a pacemaker be used in a fast heart rate? And also one about, can the leads be dislodged with vigorous exercise?
I'll take the second one. I mean, lead dislodgement is very uncommon. There's certain instructions after you have a pacemaker about, not using the left arm or raising it versus a certain level, not doing vigorous activity on that side. Obviously running or anything like that's not a problem. It's just, moving that area. So lead dislodgement is, and particularly, it's only in the first few weeks that you're concerned about that, and the rates are very, very low. Second question was, what was the second question, Isabel?
So it was about the fast heart rate.
Yeah, so the fast heart rate with AFib or flutter can really cause palpitations. And by the way, if you're running in the 130, 140 range for weeks on end without knowing it, or months on end, that actually weakens the heart. So it's not a benign thing. So normally what we'll do is we'll give patients metoprolol, or rarely we'll add digoxin to control the heart rate, but it's sometimes difficult to control the heart rate. And the medicines you use to control the heart rate can lower the blood pressure. So now you're in a pickle. That's where that AV node ablation and a pacemaker gets rid of that fast connection between the atria and the ventricles. And now you can control the issue with the fast heart rate by doing that. But traditionally, when patients are in AFib with a rapid ventricular rate, we want to slow that rate, or we want to get them back in rhythm, and we don't want to let that occur for too long, because A, it's uncomfortable for the patient, and B, it can weaken the heart muscle.
And is there, you mentioned beta blockers, is there a role for an NSVT, an indication to use beta blockers with cardiac amyloid?
Yeah, I mean, beta blockers in general are used in other conditions to reduce ventricular arrhythmias. There's no data in cardiac amyloid. So, like I said, this is all a data limited zone, but if you want to extrapolate that blocking adrenergic system may reduce non-sustained VT or VT, but we don't know that for sure. Yeah.
Thank you. And this says, please ask the doctor to address what are the parameters, I think, used to review if anticoagulation is indicated in AL amyloidosis with cardiac involvement and an ICD. Okay.
So the same things apply to ATTR and AL. If you have atrial arrhythmias, either atrial flutter or AFib of any, in my opinion, duration, that would warrant being on a blood thinner. Now, I skipped a case. There are patients who have not had a history of AFib, their normal rhythm, but their atria are so affected, we call that an atrial myopathy, that they can still form a left atrial clot even without AFib. And that's a judgment call. We kind of determine that based on an MRI and an echo and atrial function. Sometimes you will put somebody on a blood thinner, particularly with AL, who has really significant left atrial dysfunction, on a blood thinner, even though they have yet to manifest AFib.
So we had a couple of questions about watchmans, and there was one which asked, let me just find it. I may have to come back to that one. No, I can't find it. But whether it reduces cardiac output.
No, the watchman has no effect on cardiac output. Remember, the watchman is just excluding that little outpouching. I almost think of it like an appendix of the left atrium. It's excluding that, but it's not affecting heart function in any way.
And is there a chance if you had a watchman, would you also, should you also be on a blood thinner?
Yeah, that's a great question. So first of all, anytime you have one of these devices placed, left atrial occlusion, whether it's watchman or another one, they do recommend still being on a blood thinner for 6 weeks while the tissue heals around it, because you don't want blood in contact with all that material. So that's, putting in it and not putting on a blood thinner, at least for that period of time, is not ideal. Now, occasionally, we have a patient who had, a recurrent stroke on a blood thinner and decided to put in a watchman with the blood thinner to kind of, and again, this is uncharted waters, right? These are individualized. Everything I'm telling you about this here has no large, robust clinical trials to guide us, which hopefully I disclosed in the beginning, made it very clear. But yes, there are scenarios where we have done that. Just kind of, making that individualized decision because of that particular scenario.
Are there any treatments for diastolic heart failure? Any mechanical devices that address that?
Yeah, I didn't go into that. So there are these inner atrial shunt devices, so that can be placed in the inner atrial septum that are like a pop-off valve. So, when you exercise and the pressure in the left atrium goes up, that's reflected to the lungs and you get out of breath. If the pressure in the left atrium there's a little bit of a hole between the left atrium and the right atrium that blood can pop off to the right side, it may decrease that elevated pressure. And that's being studied in diastolic heart failure. There's no, approved device that you can go put in right now. There are clinical trials. I don't think that they include people with amyloid, to my knowledge. The other treatment for diastolic heart failure that we extrapolate to amyloid is SGLT2 inhibitors like Jardiance and Farxiga. And there's very good data in non-amyloid diastolic heart failure patients, but we've kind of extrapolated from that. There's a large multi-center kind of registry that Dr. Fontana was a part of that suggested maybe retrospectively there may be benefit. Remember, all the stuff we have, none of that is studied in a randomized placebo-controlled manner, but the devices for diastolic heart failure that are being tested are inner atrial shunt devices.
Yeah. And it's interesting, you've mentioned a couple of times around being studied in clinical trials. And I know there's a question which is around, are there any clinical trials that are open? And I think particularly pertinent for devices and trials that might be happening.
Yeah, so there's a device I didn't go into called CCM, or cardiac contractility modulation, which is FDA approved for people with heart failure with an ejection fraction 25 to 45%, who are still quite limited in breathing. And it basically delivers an impulse right after the QRS on the EKG, and is meant to improve the heart function. There was a few case reports that this benefited patients with amyloid. So there's going to be a small kind of pilot study looking at that in cardiac amyloid patients. Matt Moore and had been looking into trying to see a biventricular pacemaking trial. At one point, he got a lot of us together to think about doing a randomized trial with biv pacing, but that never materialized. So basically, most of what we do is extrapolation and just common sense and physiology.
And just to add in, if people sign up to My Amyloidosis Pathfinder, which you can find on the ART website, that will highlight you of any clinical trials, and maybe we can persuade Dr. Mazen Hanna to go back and come up with some new trials that patients can join. What causes the heart rate to drop to 50 or less for an extended time?
Yeah, so there's one of two reasons. One is sinus node dysfunction. So if you go back to that image, you remember the pacemaker cells that, make our heart rate go at 50 or 60 or 70, they come from an area called the sinus node, where the supravener cava and the right atrium kind of connect. And typically those cells depolarize at a rate between 60 and 100. And because the sinus node may, fire slower because there's amyloid near there, it may go 50, may go 40. Remember, endurance athletes can have a resting heart rate of 40 or 50, and that's not pathologic. I have a patient with wild type ATTR. He's 80. He's been rowing all his life, and he's an AFib, and his resting heart rate's in the 40s. No symptoms whatsoever. Didn't put a pacemaker in. So, not every patient that has a heart rate under 50 automatically gets a pacemaker. But in general, patients with amyloid don't tolerate really low heart rates because they don't pump as much blood per beat. So in order to maintain cardiac output, they need to keep the heart rate up to at least a modicum amount. But again, everybody's different. The other reason the heart rate can go too slow is heart block. So I showed you that one dramatic case of the patient who came in, he was passing out, didn't know why. And then we captured on the screen where he was having some conduction getting through. And then all of a sudden there was complete heart block, and there was a pause of, 6 seconds or so that, can cause the heart rate to go too slow. And that can cause someone to get abruptly dizzy or to pass out.
And you've talked a little bit about the dangers of living. There's another question about with constant AFib or aflutter while taking an anticoagulant and beta blocker. Is that something that you could just live with, or should you be taking action for?
No, I mean, I have many patients who just live in AFib, or even some in aflutter. As long as the heart rate's controlled, as long as they're protected with a blood thinner, it's kind of like you can't beat them, join them kind of thing. They don't feel that bad. We've already cardioverted them 3 times. We tried a medicine. It's, don't want let's say it's too advanced for an ablation, or the patient doesn't want one, or we don't, we tried it, didn't work. There are many patients walking around in AFib who are doing just fine, as long as they're protected against stroke and as long as their heart rate's not too fast or too slow. And you can regulate that either with a pacemaker or drugs to control the heart rate. I would say a third of my patients are walking around in AFib, and we just deal with it, and they do okay.
Interesting. If a patient has a high degree of pacing that's reducing EF, how strong are your feelings about the benefit of biventricular pacemakers, and are there other options?
Yeah, no, I wouldn't even hesitate in that scenario. I mean, that's approved. That's an improved indication. If someone's RV pacing and they drop their EF to that degree, then for any form of cardiomyopathy, you're on solid ground to upgrade them to a biventricular pacemaking. So I feel pretty strongly about that.
And I know we've just got time for 1 or 2 more questions, but can a watchman be used when there is a bioprosthetic aortic valve?
Yeah, I don't see why not. And again, I don't put in watchmans. I have a team of electrophysiologists who put these in, and they were part of the original studies. I mean, they put in a lot here, and the whole amyloid thing is just total uncharted waters. But like I told when I said to Isabel, sometimes you're pushed up against a wall, and you make a decision without tremendous evidence to guide you.
Yeah. And one last question, which said, would you address PVCs?
Yeah, so PVCs, or premature ventricular beats, are not that uncommon in the population. So there are people who can have, 5% of their beats can be PVCs, and they don't even know it. other people can feel PVCs. They're so bothered by them. They feel the PVC, and sometimes we just treat that with a beta blocker. Most of the time, PVCs do not cause a major problem. If a PVC is happening every third beat consistently, remember the PVC doesn't lead to a good contraction. So you're effectively 1/3 of your heart rate's not creating a cardiac output. So in very frequent PVCs, it can reduce cardiac output or cause reduction in ejection fraction, but that's very uncommon. So most of the time, PVCs are something we ignore and the patient ignores.
Excellent. Thank you. I know we're at the end of our time. This was a really informative talk. I think it was, there were some excellent questions. I've certainly learned a lot today. So thank you so much for joining us today. And as you sign off, everyone, there will be a little survey that we would really appreciate if you take a moment to fill in. It helps guide us on making sure that we provide the talks that you want to hear. So, Dr. Mazen Hanna, thank you again for joining us.
Thank you. My pleasure. Thank you.